Welcome to March 2023 Continuing Education. As you can see, we're going to keep our objectives pretty simple. We're going to identify cardiovascular causes of STEMI mimics, identify non-cardiovascular causes of STEMI mimics, define heart failure, and then discuss treatment options for heart failure. So we'll start with our introduction. One common adage in emergency medicine is that ST segment elevation in a patient with chest pain should be considered an acute myocardial infarction until proven otherwise. Like many axioms in emergency medicine, it embodies an assume the worst and rule it out later approach to patient evaluation. While such a principle concerning ST segment elevation may be prudent, the ECG is only one factor to consider when assessing patients with chest pain. A patient's history, physical exam findings, and other features of the ECG must be considered when determining the cause of ST segment elevation. In fact, the majority of ST segment elevations seen in the emergency department from patients who are experiencing chest pain are not actually the result of an AMI. Therefore, it's important for paramedics to have an understanding of differential diagnosis of ST segment elevation. In 2013, the American College of Cardiology Foundation and the American Heart Association revised the ECG definition of ST elevation myocardial infarction, or STEMI, to ST elevation at the J point in at least two contiguous leads of greater than or equal to 2 millimeters or 0.2 millivolts in men, or greater than or equal to 2.5 millimeters in men under 40 years of age, or greater than or equal to 1.5 millimeters or 0.15 millivolts in women in leads V2, V3, and or greater than or equal to 1 millimeter or 0.1 millivolt in other contiguous leads and or limb leads. That's a lot. In the updated guidelines, a new left bundle branch in isolation is no longer considered a STEMI equivalent. Moreover, the American College of Cardiology emphasized that the AMI is a syndrome, a constellation of clinical findings, including but not limited to findings on the 12-lead ECG that are concerning for an acute infarct, but also including the subsequent release of biomarkers indicative of myocardial necrosis. The mechanism by which ST segment elevation occurs in an AMI is incompletely understood. However, what is known is that ST elevation occurs reliably with transmural and subepicardial myocardial infarctions. In a classic study conducted in 1960, ST segment elevation was described as an injury current after observing its presence in a canine myocardium after ligating its supplying coronary artery. In this experiment, the injured myocardium displayed simultaneous areas of depolarized and repolarized tissue, which resulted in ST elevation. There is a competing theory that suggests that the surface of injured myocytes become more negatively charged, inducing a positive charge in the surrounding or uninjured myocytes, which then produces ST elevation. Regardless of the mechanism, the final common pathway for ST elevation is the irregularity in repolarization. Knowing all that, let's take a look at STEMI mimics. Understand there are both cardiovascular and non-cardiovascular conditions that can produce ST segment elevation mimicking an AMI. We will begin by looking at three cardiovascular causes: early repolarization, pericarditis, and bundle branch blocks. Historically, ECGs with an early repolarization pattern have been regarded as a benign variant associated with persistent ST segment elevation in individuals with no evidence of cardiac disease. In addition to ST segment elevation, slurring or notching on the downstroke of the dominant R wave is common. Early repolarization was initially associated with young, healthy athletes, but increasingly is found in a wider variety of individuals. The dramatic appearance of ST segment in multiple contiguous leads results in early repolarization being cited as the most common cause of false positive catheterization laboratory activations in patients without elevated cardiac biomarkers. The current criteria for early repolarization is the QRS slur or notch, which we call a J wave, must be on the downslope of the R wave and above the isoelectric line. The peak of the J point must be elevated at greater than or equal to 0.1 millivolts in 2 or more contiguous leads, except in V1 through V3. The QRS duration must be less than 120 milliseconds. This definition helps clinicians differentiate a normal electrocardiographic variant from ischemic ST elevation. In benign early repolarization, the ST elevation, if present, is described as concave. This is in contrast to a STEMI, which typically has a convex ST elevation morphology. However, the ST segment convexity only confers a 77% sensitivity for infarction, and therefore should not be used as the sole discriminating finding between early repolarization and infarction. There are predictors that help differentiate between subtle anterior wall STEMI over benign early repolarization. These include low R wave amplitude, which we can best see in V4, greater degrees of ST segment elevation, and longer computer measured QTC. These criteria are relatively complex to implement in a clinical setting. However, they offer a highly sensitive, about 86%, and specific, about 90%, discrimination between anterior wall STEMI and early repolarization. Electrophysiology literature suggests that early repolarization is associated, in some cases, with sudden cardiac death, such as idiopathic ventricular fibrillation, earning the term early repolarization syndrome, or ERS, or even J-wave syndrome. The J-waves seen in ERS may be indistinguishable from those that are true Osborn waves in hypothermia, since the underlying mechanism is identical. Next, we'll look at pericarditis. These patients present with positional chest pain, which is typically alleviated when they sit forward, shortness of breath, and a history of recent infection or fever. It's characterized by diffuse ST segment elevation, typically not exceeding 5 millimeters, that's present in multiple leads, and a depressed or downsloping PR segment. The PR segment is elevated or upsloping in AVR. The ST segment is concave, and reciprocal ST segment depression is never seen. Next, we're going to take a look at bundle branch blocks. A QRS with a bizarre appearance and a duration of longer than 0.12 seconds signifies some abnormality in conduction through the ventricles. A type of intraventricular conduction defect involving impaired conduction from the bundle of His to one or more of the bundle branches. Right and left bundle branch blocks are the most common findings on the 12-lead ECG. Right bundle branch blocks, or RBBBs, have a terminal R wave in lead V1. Typically, the QRS complex appears as a small r SR complex, or what we call an R prime wave, or R and R prime. Terminal S waves are also seen in leads 1, AVL, and V6. Here we have a 12 lead showing a right bundle branch block. Notice the R and R prime wave as well as the terminal S waves in lead 1, AVL, and V6. With our left bundle branch blocks, we're going to see a terminal S wave in lead V1. Terminal R waves are typically seen in leads 1, AVL, and V6. Right bundle branch or left bundle branch aberration describes the shape of the QRS complex in aberrantly conducted beads. The Scarbassa criteria can help guide the decision for emergent catheterization and coronary intervention in the presence of both new and old left bundle branch blocks. The normal state of a left bundle branch block is described by the rule of appropriate discordance. This idea is that the ventricular repolarization, or STT, occurs in the opposite direction of most of the ventricular depolarization, which manifests itself as the net polarity of the QRS and T wave being opposite from each other. Therefore, an ST segment in the same direction as the QRS, also known as concordant, is indicative of ischemia or infarction. Conversely, in a left bundle branch block, the QRS in V1 through V3 is always negative. Therefore, the normal condition of the ST segment in these leads is ST elevation. Because of this, excessive discordant ST segment elevation in leads 1 through V3 is indicative of an anterior MI. The modified Scarbassa criteria determine excessive discordance by a proportion rather than an absolute number. And these criteria have been validated. So we have three. So you have to have concordant ST elevation in greater than or equal to 1 millimeter in any single lead. Then you need concordant ST depression in greater than or equal to 1 millimeter in just one of leads V1, V2, or V3. And then the third criteria is proportionally excessive discordant ST elevation as defined by a ratio of ST elevation at the J point relevant to the depth of the S wave of about greater than or equal to 0.25. This has replaced the original third criterion of ST elevation, which was just an absolute number. Now let's look at some non-cardiac causes of ECG abnormalities. And we're going to start with pulmonary embolism. So a PE can be identified by the presence of an S1Q3T3 pattern. And then bear with me. Your S1 is going to be a deep S wave in lead 1. The Q3 is a deep, narrow Q wave in lead 3. And then your T3 is going to be T wave inversion in lead 3. And we can see that here on this 12 lead. Now, you may also have a pulmonary embolism identified by a new onset right bundle branch block. And then there are some cases where you'll also see ST segment depression in leads V1 to V3. The important thing to keep in mind here is that a thorough physical exam and then the collection of other pertinent information is crucial. Next, we have severe hypothermia. Patients may develop J waves or Osborn waves, which are often large and upright, occurring on the terminal wave of the QRS complex. The J wave may be accompanied by ST segment depression and T wave inversion. The larger the J wave, the more serious the condition is. This typically will reveal a bradycardic rhythm and baseline containing artifact from shivering and just poor electrode adhesion. Electrolyte derangements of potassium, calcium, magnesium, and sodium alter the cardiac action potential, resulting in ECG changes. Hyperkalemia frequently can cause ST elevation, most commonly in leads V1 and V2, and should be suspected when there is any QRS widening, especially when associated with some symmetric peaking of the T waves. Basically, T waves that will poke you if you touch them, as tall peak T waves. Other ECG changes in hyper-K include shortening of the QT interval, shortening of the PR interval, flattening of the P waves, loss of sinoatrial conduction, resulting in a wide complex rhythm, and ultimately ventricular fibrillation and then asystole, obviously, if it's not corrected. The ECG changes might not occur in a stepwise fashion and are more dependent on the rate of potassium elevation than on the absolute value. The easiest way to diagnose hyper-K is by measuring serum potassium, which we typically can't do in the back of the ambulance. After hyperkalemia has been adequately treated, the ECG findings should improve. Sodium channel blocker toxicity may manifest as ST elevation, particularly in lead AVR. The most well-studied SCBs are tricyclic antidepressants, or TCAs. The classic electrocardiographic findings of TCA toxicity are sinus tachycardia, with a QRS duration of more than 100 milliseconds, and a rightward shift in the terminal 40 milliseconds of the QRS. Typically, this is best demonstrated by a dominant R wave in lead AVR. There is cardiology literature that considers a QRS duration of up to 120 milliseconds as normal, but in the presence of SBC toxicity, QRS durations are greater than 100 milliseconds are associated with increased chances of seizures, and QRS durations greater than 160 are associated with an increased chance of ventricular dysrhythmia. Cardiomyopathy is a condition in which the heart muscle weakens, diminishing its ability to pump enough blood to the rest of the body. The main types of cardiomyopathy are dilated, hypertrophic, and restrictive. Hypertrophic cardiomyopathy is a genetic condition in which the myocardial walls become very thick, impairing ventricular filling. Patients will experience shortness of breath, chest pain, and syncope, often associated with physical exertion. Typically, these patients are diagnosed in their 30s and 40s, and it's characterized by deep, narrow Q waves in the inferior and high lateral leads, and very tall R waves in the left precordial leads. In most cases, the disease is inherited. There are other cases, though, where the cause is unclear or unknown. With restrictive cardiomyopathy, the ventricular walls stiffen due to abnormal substances deposited between the heart muscle cells throughout the heart, or because the inner surface of the heart is lined with scar tissue. The rigidity of the ventricular walls hinders ventricular filling, and the heart eventually loses its ability to pump adequately. Here we have a 12 lead showing evidence of hypertrophic cardiomyopathy. Left ventricular hypertrophy, or LVH, is known to cause many false positive cardiac catheterization lab activations. The electrocardiographic diagnostic criteria for LVH all have poor sensitivity. The most specific and widely used criteria are the Sokolow-Lyon criteria, which confer a specificity of 100% and consist of the following: the amplitude of the S wave in V1 plus R wave in V5 or V6 that is more than 35 millimeters, or R wave amplitude R wave amplitude in V5 or V6 that is more than 26 millimeters. Brugada syndrome is considered a part of the ERS spectrum. For many years, it was called a sleeping sickness in Southeast Asia because it referred to young men who would scream in the middle of the night and suddenly die. In 1992, Brugada syndrome was described initially by the Brugada brothers as a right bundle branch block with persistent ST elevation in patients presenting with syncope and dysrhythmic events. However, it should be noted that Brugada syndrome is defined as the ECG pattern in addition to symptoms. So syncope, palpitations, and apparently sudden death is also a symptom. If seen in isolation, the Brugada ECG pattern is referred to as a Brugada sign, and its significance is dependent on the patient's clinical context. It's thought that the Brugada syndrome is the cause of death in about 4% to 5% of sudden death cases, particularly in young males. The ECG pattern in Brugada syndrome looks like an R wave in which the ST segment has a gradual downslope, such that a 40 millisecond after the ST takeoff will increase the amplitude to about, less than 4 millimeters. The abnormal ST segment may be mistaken for ST elevation, particularly in patients who present with ventricular dysrhythmias. There are two, which there used to be three, but there are two ECG patterns in Brugada syndrome. The most recognized Brugada ECG phenotype, which is type 1, has ST elevation in V1 through V3 of a coved or convert variety, and it's frequently identified as a right bundle branch block. Type 2 has a saddleback ST morphology with greater than 2 millimeters of ST elevation. The Brugada ECG phenotype may be transient and exacerbated by the presence of sodium channel blockers, fever, or may not even have an identifiable precipitant. Patients with Brugada syndrome must be evaluated for internal cardioverter defibrillator placement to prevent sudden death. Since the absolute risk of death in patients with isolated Brugada sign is unknown, emergency providers should recommend follow-up with cardiology. ST elevation caused by vasospasm has an identical morphology to that of a true STEMI, even though it's not caused by coronary artery endoluminal plaque rupture or intraluminal thrombosis. Vasospastic angina, which we used to call prismatal or variant angina, occurs as the result of coronary artery vasospasm, which produces ST segment elevation along with the involved coronary territory. In vasospastic angina, administration of nitrates or benzos usually resolves the chest pain and the ST segment elevations. In the ED, it's often difficult to distinguish vasospastic angina from STEMI, and as such, patients with chest pain and ST elevation should always undergo an evaluation for ischemia. An example of vasospastic angina occurs after cocaine use. Cocaine causes ischemia because of its adrenergic stimulation, causing vasospasm as well as causing increased myocardial oxygen demand. Chest pain is a common complaint in patients with cocaine toxicity, and the cocaine-associated chest pain study group determined that there was no clinical parameter that could identify patients with very low risk of cocaine-induced MI. In addition to cocaine-induced MI, chronic cocaine users are at an increased risk for accelerated atherosclerosis, which further predisposes them to acute coronary syndrome. Long QT syndrome is characterized by a QT interval exceeding approximately 0.45 seconds. This indicates that the heart is experiencing an extended refractory period, and this predisposes the ventricles to dysrhythmia. Most commonly, this is a result of genetic mutation of several genes, but it can also occur due to amiodarone administration or certain conditions such as hypocalcemia, AMI, and pericarditis. The long QT interval is age-specific and gender-specific. Male patients who are younger are typically at risk. Patients are at an increased risk for ventricular dysrhythmias, including torsades and ventricular fibrillation. Chest pain is a common cause of ED visits. In patients with ECG findings consistent with a STEMI, the primary goal is to salvage myocardium through rapid reperfusion. However, before activating the cardiac catheterization lab, it's important to consider non-ischemic causes to ST segment elevation. The goal here is to provide paramedics with tools for ECG evaluation that will help identify some of the most common STEMI mimics. Now let's take a look at heart failure. Heart failure is a common medical problem in the United States, and it's experienced by approximately 5.1 million persons, with more than 650 new cases diagnosed annually. The incidence of heart failure increases with age, and for Americans over 40, the lifetime risk of developing heart failure is 20%. It occurs most frequently among Black men and least frequently in white women. Heart failure occurs when the heart cannot pump fast enough or powerfully enough to empty its chambers. Blood backs up into the systemic circuit or the pulmonary circuit, or both. Heart failure is a syndrome, not a disease. It's caused by any of several disorders that impair the ability of the ventricles to fill or eject with blood. We identify this based on symptom onset or the ventricle that's initially involved. Although failure of either ventricle can occur by itself, they do often occur together. Right ventricular failure is often the result of left ventricular failure. Typically, this is caused by disorders of the pericardium, myocardium, endocardium, or the great vessels. The most common cause is coronary artery disease, but valvular heart disease, dysrhythmias, cardiomyopathy, and long-standing high blood pressure can also cause heart failure. Again, heart failure is the inability of the heart to produce adequate cardiac output to meet the perfusion and oxygenation requirements of the body's tissues. It's a complex clinical syndrome that can arise from any structural or functional cardiac disorder that impairs the ability of the ventricle to fill with or eject blood, resulting in a decreased cardiac output. And there are two mechanisms by which this can occur, either through systolic dysfunction, which the result of impaired cardiac contractile function is, or diastolic dysfunction, which is the result of abnormal cardiac relaxation, stiffness, or filling. Now, let's define a few things first. Cardiac output is the blood volume that the heart pumps through the systemic circulation over a period, and it's measured in liters per minute. There are various parameters utilized to assess cardiac output comprehensively, but one of the more conventional approaches involves multiplying the product of the heart rate and the stroke volume. Stroke volume is the volume of blood pumped out of the left ventricle of the heart during each systolic cardiac contraction. Now, we don't always know exactly what the stroke volume is, but the average stroke volume of a 60 kg male is 70 mLs. Preload can be defined as the initial stretching of the cardiac myocytes prior to contraction. Afterload is the pressure that the heart must work against to eject blood during systole. Afterload is proportional to the average arterial pressure. As aortic and pulmonary pressures increase, the afterload increases on the right and left ventricles respectively. Cardiac contractility represents the innate ability of the heart muscle to contract. Now, heart failure can be caused by any condition that affects your preload, afterload, contractility, or heart rate. Now, think back to paramedic school. You probably remember Starling's law. So according to the Starling law of the heart, increased venous return augments preload. Heart muscle fibers stretch in response to the expanded volume, or preload, before contracting. Stretching allows the heart to eject more forcefully, thereby boosting stroke volume. In the normal heart, the greater the preload, the greater the force of ventricular contraction, and the greater the stroke volume. And this is going to result in an increased cardiac output. There are two types of left ventricular failure. Systolic failure is where the left ventricle doesn't contract normally and has trouble pumping out all the blood into the body. Diastolic failure is where the left ventricle contracts normally but has become stiff, impeding its ability to relax and fill with blood between each contraction of the heart. Common causes include a faulty heart valve, AMI, cardiomyopathy, or excessive volume or pressure. With left ventricular failure, blood backs up behind the ventricle, causing a chain reaction. The right side continues to pump normally, but the left side can't keep up and the pressure increases. Because of this, pressure within the pulmonary vessels will increase, and fluid is forced out of the pulmonary capillaries into the alveoli, which then results in pulmonary edema. The buildup of fluid widens the gap between the alveoli capillary membrane, impairing the diffusion of oxygen and carbon dioxide. When blood cannot keep up with the increased workload, the right ventricle fails. Blood backs up behind the right ventricle, raising pressure in the right atrium. Blood backs up into the posterior and inferior vena cava, and the veins become congested with blood. From there, the organs will become congested with blood. Rising pressure within the veins forces serous fluid through capillary walls and into the body's tissues, which produces edema. Peripheral edema is most often apparent in the feet and ankles. But that's not the only place where it can build up. Serous fluid may also build up in the abdomen, which we call ascites, the pleural cavity, which we would call pleural effusion, and the pericardial cavity, which we would call pericardial effusion. As RVF progresses, generalized edema of the entire body may occur, which we call anascara. RVF may occur by itself without LVF in conditions such as right ventricular infarction, pulmonary embolism, or pulmonary hypertension. Pulmonary hypertension is a disorder in which the pressure of the pulmonary arteries is higher than normal. The right ventricle must work hard to overcome the increased resistance to eject blood, and the right ventricle will then enlarge and eventually fail. There's also something known as cora pulmonale. This is a pulmonary disease that's usually the result of COPD. When assessing these patients, understand that they may report a sudden onset of shortness of breath, or a shortness of breath that is worsened over a period of hours or days. It may persist even at rest. The likelihood of a cardiac origin is greater if the patient has a history of heart attack, high blood pressure, valvular disease, or any number of cardiovascular conditions. The patient may report that they've had trouble sleeping. Patients may often report feeling tired or weak. They may have had trouble concentrating, which is typically the result of hypoxia. Other symptoms will include nausea and a loss of appetite, feelings of faintness, palpitations, or just an irregular rapid pulse. And ask them about prescribed medications, specifically beta blockers or calcium channel blockers. Patients may also complain of restlessness, anxiety, or just unexplained confusion. Again, could be the result of hypoxia. The sympathetic nervous system's response to hypoxia and the body's compensatory mechanism to maintain CO causes these symptoms. You'll see symptoms such as rapid respiratory rate and heart rate, pale and cool skin, diminished peripheral pulses, and an increased work of breathing. As hypoxia worsens, the patient may become cyanotic or may cough frequently. They may produce pink, frothy sputum when they cough, and the buildup of fluid in the lungs will typically cause crackles or rales and sometimes even wheezing. If RVF accompanies LVF, then jugular venous distension will possibly be visible as the venous system becomes congested. Patients who are still able to walk will typically have swelling of the ankles, feet, calves, or legs. If they're confined to bed, they'll typically have swelling in the sacral area, whichever is the lowest point of gravity. Remember, if edema is present, you want to note and document if it's pitting or non-pitting and localized in the ankles to the mid-calf or to the knees. Remember, ascites may also occur. As the pump continues to fail, the heart rate will begin to slow. Your blood pressure will fall, and the cardiac output will decrease substantially. Cardiogenic shock will then occur when heart failure is accompanied by hypotension. The goals when it comes to managing these patients is to decrease respiratory distress and worker breathing, maintain adequate oxygenation and perfusion, and direct supportive efforts towards decreasing the workload of the heart. It's important to offer the patient reassurance, particularly if they're experiencing anxiety related to hypoxia. Place them in a position of comfort, typically in a sitting position with their feet dangling. These patients are not going to want to lay down, nor should they. This encourages venous pooling in the legs, which does reduce venous return to the heart, which in turn decreases the work of breathing. It's a good idea to apply a pulse oximeter and an end-tidal CO2 monitor, and then provide supplemental oxygen as needed to maintain the patient's SpO2 at least 94% or higher. You can use non-invasive positive pressure ventilation to manage pulmonary edema associated with heart failure. And because of this, a patient can receive the following benefits: improve oxygenation and perfusion, maintaining alveolar function. It'll improve the patient's pulmonary compliance, slow their respiratory rate, which will decrease their work of breathing, heart rate, and systolic blood pressure. It can help facilitate the delivery of bronchodilators. It can reduce preload and afterload, which will improve cardiac output, and it will decrease the patient's work of breathing. Do not use non-invasive positive pressure ventilation if the patient has a compromised airway, altered mental status, risk of aspiration, pneumothorax, or a systolic of less than 90. At that point, you probably are better off using an advanced airway. If you use the advanced airway, you should definitely be using waveform capnography. Even if you're not using an advanced airway, remember you need to limit the patient's physical activity. Additionally, place the patient on a cardiac monitor and obtain a 12-lead ECG. Establish IV access, because there are some pharmacologic therapies that might apply for heart failure patients, though they do vary slightly from EMS system to system. Sublingual nitro may be given to reduce both preload and afterload. Furosemide, however, is not currently recommended for use in treating heart failure and acute pulmonary edema, though we still see plenty of EMS services that are using it. Surgically implanted ventricular assist devices, or VADs, may be used in patients who have heart failure, though we're not going to be placing them as paramedics. Essentially, these act as an artificial ventricle that doesn't depend on the contractility or the electrical conduction of the patient's heart. Now, typically, we see them placed in the left ventricle, or the LVAD, but you can see them placed on the right side, or even both biventricular, so a BiVAD. LVF is more common than RVF, so the LVAD is the most common type of VAD. And it may be used in the following situations: to allow the heart to rest until the patient's heart can resume its normal function, as a bridge to heart transplant, or, as we're seeing increasingly, something known as destination therapy, which is a lifetime therapy. There are several different types, but they all typically consist of a pump, tubing, an external power source that connects to a controller, and then a very loud alarm. They are categorized according to their type of blood flow, whether it's continuous or pulsatile, the length of time the device can be used, such as short, immediate, or long term, the source of driving power, be it pneumatic or electric, and the device location. The patient's weak or absent pulse may make obtaining a blood pressure using a normal blood pressure cuff and stethoscope impossible, as well as obtaining a pulse oximetry reading. The different types of VADs include transcutaneous, where both the pump and the power source are located externally; implantable VADs, where the pump is located inside the body and the power source is located externally. Tends to be the most common. And again, LVADs is where blood is withdrawn from the left atrium or the apex of the left ventricle through a tube into the LVAD and then returned to the ascending aorta via a second tube. RVADs is where the blood is withdrawn from the right atrium into the RVAD and then returned to the pulmonary artery. Complications with VADs include device malfunction or failure, thromboembolism, bleeding, RVF infection, or sepsis. A VAD coordinator can assist you in making treatment and transport destination decisions. Contact the VAD coordinator if the patient with the VAD experiences a cardiac arrest. You're not going to be able to do chest compressions on these patients because you're just going to rip the device out of their heart. If the patient does require defibrillation or cardioversion, please do not place the pads directly over the pump. Most of the time, the VAD coordinator is going to talk you through how to resuscitate these patients.